Hi, I'm Mike Knetter, and welcome to another edition of our UW Now Livestream series, where we bring you experts from the UW community to talk about various aspects of the COVID-19 crisis. Tonight, you might say this is our encore edition. We have three guests with us who've been with us before, and they'll share updates on what we learned from them last time. Joining me this evening are three Badgers with 6 UW degrees between them. Thomas Friedrich is a professor of pathobiological sciences in the School of Veterinary Medicine. The Friedrich Lab studies RNA virus evolution, transmission, and pathogenesis. Phill Gross is the co-founder and managing director of Adage Capital, who has spent his investment career analyzing the healthcare sector. Nasia Safdar is a professor in the Division of Infectious Diseases, vice chair for research in the Department of Medicine, and medical director of infection control at UW hospitals and clinics. As always, we ask that you submit your questions to our guests this evening in the live chat feature of YouTube. So let's get started. Our first guest this evening will be Phill Gross, who received his undergraduate and master's degrees from the Wisconsin School of Business in the early 1980s and earned WAA's Distinguished Alumni Award last year. Phil's the co-founder and managing director of Boston-based Adage Capital Management, which invests over $30 billion worth of assets, mostly for nonprofit and academic endowments and foundations. Adage has outperformed the S&P 500 in 17 of the 18 years of its existence. The firm is known for its unique analyst-driven investment strategies and for giving refunds to investors when the fund underperforms. Not often, as we just heard. Phill is responsible for managing one of the healthcare portfolios, and prior to founding Adage, was a partner at the Harvard Management Company for 18 years. If you listen to our prior segment with Phill, you'll know he's been keenly following all aspects of the COVID-19 crisis, as he spends a lot of his time investing in companies that are working on various aspects of testing, treatment, and vaccine. So, Phill, thanks for taking time and joining us again tonight. It's great to have you back. Take it away.
Hey, thanks for the kind intro, Mike. It's an honor to be back with you again to cover this important topic with two experts joining the conversation. I'd like to jump right in and review some of the predictions and assumptions we made last April. Last April, we said this would be a regional rolling epidemic, and that in fact proved to be true as the Northeast rolled into the South and Midwest and other hotspots across the country. We also laid out a plan for the American Enterprise Institute and Dr. Scott Gottlieb, former FDA commissioner, to open states carefully as they meet certain criteria. This didn't happen across the country, and there were several places that opened up before really they were ready. And it's part of the reason we saw a second surge of the virus over the summer months. We also asked, is COVID a seasonal virus? And the answer there was no. It's probably a big disappointment along with the opening criteria in terms of whether this vaccine was similar to flu or not. And it's just not your average flu virus. It's more infectious and it tends to be resilient through the summer, high humid months. In therapeutics, Nasia will cover this in more detail shortly, but suffice it to say remdesivir worked, hydrochloroquine did not, anti-inflammatories did not. Therapeutic antibodies are going to be releasing data soon, and steroids emerged, somewhat surprisingly, as a life-saving therapy in severe COVID patients. Meanwhile, treatment protocols for COVID patients have definitely improved over these last few months. And vaccines have remained on an accelerated timeline for approval and launch. So the question I'll ask right now is, will there be a fall surge or a third wave? And the answer is yes. You may actually be seeing this in Dane County already, as folks spend more time indoors with lower humidity, less attention to social distancing, et cetera. You've heard it all. But we need to understand that the second wave was less severe than the first one. New cases grew almost 100% or over 100%. The hospitalization rate was cut in half, and mortality was 50% lower than the first peak, even with 2 times the number of infections. So if we go to the next slide, we asked the question, why are severity and mortality moderating? Again, Nasia will get into some of the real world details from the UW healthcare system here. But looking at the US in total, it's clear that the average age of infected patients is lower than it was in the first peak. There are much better treatment protocols. We understand the disease process a little better. Doctors do. So anticoagulation, less intubation, et cetera. There's better therapeutic interventions, which again, we're going to talk about shortly. And of course, there's asymptomatic positives in the testing pool. We've all decided to get tested or had our friends get tested and family in order to create our own bubble. And that obviously has probably led to a few asymptomatic positive patients in the testing pool. What's important about this whole difference between the first wave and the second wave is what will happen if we see improved outcomes and better treatment if and when there's another surge. How will local communities, including places like Madison, react to a spike in infection rates that doesn't necessarily lead to a dramatic surge in hospitalizations and mortality? And that's something that we should all be thinking about. Next slide, thoughts on testing. Tom will be talking about this later, but suffice it to say, there will be a transition toward point of care versus lab-based tests. They're faster, cheaper, they can be made in high quantities, but they're less sensitive. And as Dr. Friedrich, as Tom will point out, this can be offset by serial testing. And there is a question about how sensitive is too sensitive, which he'll get into in a moment. One example, Abbott's just launched antigen test, can supply 50 million tests a month starting in October. And they just sold their first 150 million tests to the US government for just $5 a test. Therapeutics. Again, Nasia will be talking about the first two of these, steroids and convalescent plasma. There's two upcoming events that we should pay attention to. Therapeutic monoclonal antibodies will have phase 3 data, real phase 3 controlled data available from Regeneron and Roche in September and October, and from Lilly in October and November. We need to understand that in the Regeneron case, the manufacturing capacity is just 650,000 to 4 million hospitalized patients a year. That's not enough to be used prophylactically, and it's not even enough really to treat every hospitalized patient in the COVID sphere. And I think it's just an important fact to know that this data may be positive, but it's probably going to have the greatest impact on later stage patients. One thing to watch for that nobody's really talking about are oral antiviral data and therapies from Merck, Pfizer, and a company called Atia. This will come out in the October to December timeframe. And the idea that an oral remdesivir is out there could be a game changer. So that's very, very important. You can make a lot of it, you could treat a lot of patients, and you could treat them early. So the rest of the time, I'd like to look into vaccines. There's a lot going on. There's a lot of recent publicity about this. Operation Warp Speed is something that was talked about a lot and really was a mystery to most experts following the vaccine field until this paper was published in the New England Journal of Medicine in August, a couple of weeks ago. Basically what it says is Operation Warp Speed leverages the full capacity of the US government to ensure that no technical, logistic, or financial hurdles hinder vaccine development or deployment. So if we get into the details on the next slide, the details of Operation Warp Speed is the goal is to have tens of millions, note not hundreds of millions, of safe and effective vaccine doses available in the US by year-end 2020, and 300 million doses deployed by mid-2021, which would be enough to vaccinate most of the US population. There's 8 vaccines in the Operation Warp Speed portfolio, 6 of which have been chosen. We'll talk about that in a second. 2 each will be chosen from 4 different vaccine platforms to spread the risk. The federal government is going to pay for and fund process development, manufacturing scale-up, and clinical trials. And these trials will enroll between 30,000 up to 50 or 60,000 subjects for each vaccine. To further facilitate this, the government will purchase upwards of 100 million to 500 million doses of each of these vaccines before seeing the full phase 3 clinical data. So they'll manufacture these vaccines, they'll be ready to be rolled out, so that whichever one seems like the best vaccine with the best profile will be ready to go to treat the US population. Next slide. So let's talk about the issue of the day. How soon will a vaccine be ready? The CDC said last week to get ready for early November, which sparked a backlash and made this basic question kind of a political football. But there is, in fact, an answer. And the most important fact for all of us to know is that no matter what, a vaccine that has data this fall will only be available for high-risk groups and will have very, very early efficacy and safety data. Next slide. So here's a spreadsheet that tries to lay out the timing for an enrollment cadence and data flow for the 6 disclosed Operation Warp Speed portfolio vaccines. We know that the FDA normally requires at least 6 months of efficacy and safety data to approve a vaccine. But the fact is, the FDA has agreed to an accelerated review process of the vaccine manufacturers, as disclosed by the company, for emergency use of a COVID vaccine. They're allowing interim data analysis very early in the clinical trial. And in fact, this interim data analysis that's in the orange box with the red arrow here above, it's going to take place after only 50 to 150 symptomatic infection events have occurred out of 30,000 subjects enrolled in these trials. Very, very early. It's only really going to measure the subject's initial antibody response to the vaccine, not the longer-term memory T-cell and B-cell immunity of the various platforms. That will have to wait for the 6-month readout next year. So, on the next slide, there's still a fear that a vaccine will be released before it's truly ready, and the media has stoked that fear as well. That could mitigate confidence in the vaccine when it is released. So the 9 CEOs from the vaccine manufacturers made the pledge that was released today. It said a couple of things that are really important. Always make the safety and well-being of vaccinated individuals our top priority. And these are direct quotes. And only submit approval for emergency use authorization or full approval after demonstrating safety and efficacy through a phase 3 clinical study that is designed and conducted to meet requirements of expert regulatory authorities such as the FDA. That's the catch. What does it take to meet those requirements? Next slide. Let's go back to our timing spreadsheet. The fact is the FDA has agreed to interim analysis of safety and efficacy as disclosed by the companies. This interim data analysis will also take place after nearly all 19,000 to 30,000 subjects will have been vaccinated, and any early safety signals will have been observed. Is that safe enough for widespread use? Probably not. Is that safe enough to vaccinate high-risk individuals under an emergency use authorization? The answer there is maybe, and we're not even sure within the FDA what that decision might look like. Is that enough data for any of you personally to take a vaccine? That's what the pharma CEOs are really worried about. They can't get this wrong and undermine the confidence in the whole vaccine program in the US. I'd focus on the data coming in the far right column of this sheet, the 6-month efficacy and safety readout between March and June of next year. We'll have long-term efficacy and safety, or I would say intermediate-term efficacy and safety, and we'll be able to compare these vaccines with each other. So let's quickly compare the vaccines. Next slide. There will likely not be a winner-take-all market. There will be obvious and subtle differences between the vaccines and which populations they are most effective for. And as we see the short-term and longer-term safety and efficacy data between October and next April, this will become more clear. We don't know anything really about the comparison right now in terms of efficacy and safety. All of the data thus far has been surrogate immune response data and using assays that are very difficult to compare. But there are important differences we do know. First of all, on price. Johnson & Johnson and AstraZeneca, AZN, are willing to sell their pandemic supply at cost on a nonprofit basis. This could throw a wrench into the profit margins of the other players if these vaccines have similar efficacy. Storage, the first 2 vaccines must be shipped between -20 degrees and -80 degrees centigrade. The logistics of widespread use are already going to be extremely complicated enough, so it's certainly a disadvantage if a refrigerated or room temperature vaccine has decent efficacy. And dosing. J&J in the second wave vaccine may be efficacious after just 1 dose. Again, a big advantage if efficacy is similar. So definitely stay tuned. You have to point out that meeting these objectives for efficacy and safety is not a done deal in any way, shape, or form. AstraZeneca's vaccine, in fact, has already paused their enrollment because of a single safety event that occurred in their trial. So there is a lot to be determined over the next 2 or 3 months and over the next 6 to 9 months as well. Next slide. Why does a healthcare analyst focus on this? A lot of people asked me the last time, why do you know about what's happening in the COVID space? Well, this is a good example. In just these 3 of the 6 operational warp speed equities, 31.7 billion in market cap has been generated since March 12th, and they are together worth 47 billion. And the question is whether that's rational or not. A reference is the entire pandemic vaccine opportunity in the developed world is about $22 billion at $20 per course of therapy. And $20 per course of therapy may not be the right price if the nonprofit vaccine makers have decent data. So the real question becomes, on a longer term basis, who will win, of course, and what will that win look like? And will there be a seasonal opportunity beyond this pandemic that stretches a single opportunity out over months, over years? Well, thanks for listening. Conclusions: there will be a third wave, but outcomes from infection may be less severe and will put less pressure on the healthcare system. And Nasia is about to talk about that. Rapid testing will expand because it's faster and cheaper and can supply more tests. Tom will talk about that a bit later. And therapeutic progress has been made and will continue to be made and could be significant and worth watching this fall. Vaccines are coming soon, but clarity on safety and efficacy and broad availability will still have to wait until next year. So that's it from me. Nasia, take it away.
Well, thank you, Phill, for that great overview of what's going on with testing, treatments, vaccines, and the like. You can buckle up and listen to our next 2 speakers and get ready for Q&A. Our next speaker is Dr. Nasia Safdar, who earned her master's degree in 2002 and her PhD in 2009, right here at the University of Wisconsin. Dr. Safdar is a professor in the Division of Infectious Diseases, the Vice Chair of Research in the School of Medicine and Public Health, and the Medical Director of Infection Control at UW Hospitals and Clinics. She leads the Department of Medicine in its mission to reduce and prevent healthcare-associated infections by identifying, testing, and implementing novel interventions. Because of her work and research in this area, Dr. Safdar received a President's Early Career Award for Scientists and Engineers in 2017, the highest honor bestowed by the U.S. government on outstanding scientists and engineers beginning their independent careers. In 2014, she received the John Q. Sherman Award for Excellence in Patient Engagement. Dr. Safdar is a fellow of the American College of Physicians and a member of the Society of Internal General Medicine. Dr. Safdar, you are our first speaker on our UW Now Livestream series, and it's great to have you back. We look forward to your update. Thank you for joining us.
Thanks very much, Mike. Looking forward to discussing updates on COVID-19, and perhaps we could go to the first slide. So I'm going to be talking about a health systems perspective, and of course, although my perspective is that of UW Health, the observations that I'm making will really apply to almost all health systems that are engaged in any way in the care and management of patients with COVID-19. If we go to the next slide, the things I'm going to be discussing, as was mentioned, will be the management of COVID-19 and how that has changed, particularly in hospitalized patients, where we now have several more options than we did early in March when we first started to learn about this pandemic. And then what sort of challenges have come about now 7 months into this? What have we learned and what can we expect in the future? If we go to the next slide, this is one of the most telling slides I think that the CDC has put out recently. Before this, it was difficult to really see in a snapshot what the national data on hospitalizations looked like. And you can see here on the y-axis is the rate per 100,000 population, and on the x-axis is the time. And you can see this marked difference between hospitalization rates by age, such that the younger age group, we're seeing very few hospitalizations in, and then it rises for every decade of age, with the highest being in the 65 and older age group. This has profound implications for how health systems prepare, what sort of mitigation activities must be undertaken, because this group is exceedingly vulnerable to complications of COVID were they to require hospitalization. If we go to the next slide, this is what the current situation looks like. So the question that we're asking is, to what extent is the very vulnerable age group accounting for the percentage of cases that we're seeing in Dane County? So this is data that has been updated as of last week. This refers to Dane County. You can see that the 20 to 29-year-old age group here accounts for about 19% of the Dane County population, but has accounted for as high as 54% of cases back in the early days of July, and even now account for about 30% of the cases that are happening. The older age group, more vulnerable to hospitalization, is accounting for far fewer cases. And I think this explains why hospitalization rates have so far not overwhelmed the healthcare system. But of course, as you know, from the perspective of the virus, the 20 to 29-year-old or the younger age group is really the perfect host. These are individuals that, if they do get COVID, tend to, as a group, not get severe symptoms. And so their physical mobility can remain fairly undeterred, allowing the virus to propagate, with the end result that diffusion can occur in older age groups who then will require medical care and hospitalization. Next slide. This is what our dashboard and our registry looks like for one health system in town here. You can see that these are the number of cases overall that have been treated. These are inpatients. Some have required more than one admission, and therefore this number is higher than the total number of hospitalized patients. Many have been successfully discharged, and our average and median, in this case, length of stay and the days on the ventilation, on mechanical ventilation, mirror what is being reported nationally. There is in the literature a slight preponderance among more cases occurring in men, and most of our patients have been white. As far as the admissions by age group goes, again, the same thing that I just mentioned, which is that the older age spectrum accounts for the large proportion of hospitalizations. In this pie chart here, you can see GC stands for general care, this is intermediate care, and this is ICU care, so just progressive higher acuity of care. And you can see that it's about half and half. Half the patients do not require intensive care, and half have done so. Now, the other important thing to see in this slide is how the number of hospitalizations have crept up as the days have gone by. And even though, you know, it's been reassuring that the health system has not been overwhelmed and we have not outstripped, or demand has not outstripped our capacity, this sort of relentless slope here has been and will continue to be taxing on the health system until such time that we have an efficacious and safe vaccine, which is really expected to turn the tide. Next slide. As has been reported in the literature, most of the time that when we see patients requiring hospitalization for COVID-19, we do find that there are a number of comorbid or companion illnesses that lower their and weaken the reserve in the form of either lung disease, heart disease, chronic kidney disease, for instance. So most of the patients that get hospitalized have some or more of these conditions. On the right side here, you can see this is each patient, and you can see that there are several patients. If each rectangle is a chronic illness, there are several that have more than one, some as many as 8 or 9, and all of these then play into whether the stay in the hospital is uneventful, whether it's complicated, whether ICU care may be needed or not needed. Next slide. So what are the advances in management? I think one key thing that Phill touched on is that our overall understanding of pathogenesis and outcomes of COVID-19 has markedly improved since earlier this year. And so the general supportive care for COVID-19 has become a lot better, which has translated then into really improved outcomes, even independent of specific therapies that are listed here. And one of them is actually the avoidance of intubation. Early in the pandemic, there was this feeling, and born of the best intentions, but this feeling that perhaps patients with COVID-19 should be intubated early on to minimize exposure and spread to other patients and healthcare workers. And in fact, it turned out that not only was that necessary, it also wasn't the best management strategy. So learning from evidence and applying it as soon as data comes out is the hallmark of science, and it's so important to do that in the health system as well. So overall, that by itself has improved care. But the three things specifically that I think are worth discussing in the context of management are remdesivir, convalescent plasma, and corticosteroids. So if we go to the next slide, you'll see what the data looks like for remdesivir. This was published in the New England Journal several months ago. This was a double-blind, randomized, placebo-controlled trial of intravenous remdesivir, and they looked at really two things. The primary outcome was the time to recover, and it was defined as either being discharged from the hospital, or if you needed prolonged hospitalization, it really was for the purpose of discharge disposition and not active management. And so what were the results? If you go to the next slide, this data shows you what the findings were. So, they're, in the big scheme of things, are not terribly compelling if you first look at it, because those that received remdesivir had a median recovery time of 11 days, and those that received placebo had a median recovery time of 15 days. So there's a median difference of 4 days then in the time to recovery. But when we're thinking about health system preparedness, about patients recovering, being able to go home, this is, of course, a huge win in the world of therapeutics. The trial was not powered for mortality and did not see a mortality benefit. This led to an emergency use authorization for remdesivir, and now most of our patients and others in health systems that are being hospitalized are getting remdesivir as standard of care. Next slide. A somewhat similar path has been followed by convalescent plasma. This is a preprint which is expected to be out very soon, which for the first time has described in a large patient population the effect of convalescent plasma on mortality in hospitalized patients with COVID-19. This was a 3-month experience. It was from multiple healthcare institutions and was really designed to be a very pragmatic examination of the value of convalescent plasma. So on the next slide, as we see the results, this is a complicated table, but I'll just point you here to take a look at first this here. So this is crude mortality, both 7 and 30 day, of patients that received convalescent plasma. It is critical to understand that this was not a randomized controlled trial, and so there is no comparator. It is a large case series of 35,000 patients, all of whom received plasma. So you really cannot compare mortality between those who got it and those who didn't get it, because there were no patients who didn't get it. So in this sample size, the mortality overall was 10%. A large proportion of these patients were in the critical care setting. This was 7-day mortality, and then 30-day mortality was 24.5%, which is about what you would expect to see in that group of rather sick individuals. The main findings from this trial, or from this study rather, that have received a lot of media attention is this little subgroup analysis here. And so this is the level of IgG antibodies in the plasma. And when the level of IgG antibodies were high, then mortality was low. And when the level of antibodies was low, then that translated to higher mortality. You will notice that this entire analysis only had about 3,000 patients in it, and not the full 35,000 that were a part of the overall study. So the bottom line is convalescent plasma possibly, perhaps, works, but we don't know that for sure. And there are several randomized controlled trials that have been undertaken around the country to try to answer this question in a rigorous manner. However, in part because of the results of this study, the FDA agreed to an emergency use authorization for this convalescent plasma as well. And that has had, or will have, I think, the effect that most patients will expect to get convalescent plasma. Most healthcare institutions will feel that they should offer it. And we may have issues enrolling patients into clinical trials to the point that we may never know if convalescent plasma actually truly really works the way that we hope it does. Next slide. There's little debate, though, about corticosteroids, which is very interesting because corticosteroids have been studied for 50 years for all kinds of lung conditions that required ICU care. And the data was all over the place, and nobody was terribly excited about the fact that dexamethasone may, in fact, impact outcomes for COVID-19 until it was clearly and conclusively shown that it did. This was a very well done, controlled, open label trial that compared dexamethasone to usual care. And if you go to the next slide, this was a pretty compelling outcome. They looked at 28-day mortality, and you can see that here mortality is on the y-axis, days since randomization is on the x, and you can see that people who received usual care had higher mortality than those that received dexamethasone. And so dexamethasone is now standard of care for the management of COVID-19 patients who require ICU care. And that has been gratifying to see that there is actually something that we know for sure works quite well in this setting. Next slide. As far as the vaccine goes, Phill already touched a great deal on the vaccine, so I'll just say that UW Health is participating in the AstraZeneca Oxford vaccine study trial. About 1,500 are expected to be recruited, and there has already been thousands of people that have signed up and have expressed interest. Enrollment, whenever it is resumed, will continue. There are, of course, several other vaccine candidates in clinical trials as well, and we wait to see what the results of those will be. I think, as we all recognize, vaccine hesitancy has become a real issue, particularly in this country, where already I think scientists and others were having challenges getting people to not just enroll in trials, but actually to take the vaccine when it became available for anything, even childhood illnesses, even though we all believe that the greatest success of the last 100 years in public health has been vaccines for preventable conditions. And for anyone that doubts that, you only have to go to a lesser developed country or to a place where those vaccines are not available to see the ravages of those preventable conditions. But there is one fundamental difference, I think, between those vaccines and the one that we're currently preparing for COVID-19, which is the trust that the public has. And if that trust is not there, then we will find that people will not take the vaccine, even when it is proven to be efficacious and safe and available. So if you go to the next slide, I think it's going to be absolutely critical that we handle the vaccine as we would from the perspective of being as rigorous as one can make it. So from the health system's perspective, we use the 4S framework developed by Paul Farmer many years ago, which really boils down to 4 basic things. There's supplies, there's space, there's staff, and there's a system. And if all of these are not in place, then we will find it very difficult to cope with COVID-19. So from the supply standpoint, the biggest thing is, of course, is personal protective equipment. And even though we are in a better place now than we were before in terms of the overall supply, there are still disruptions and shortages and issues in the supply chain that really have made us very wary of going back to the way that we used to before COVID. So an example of that is, a disposable surgical mask would be used one time and would be thrown away before COVID because that's how it's made and that's the intent. We now reuse it for several days. We cover it with a face shield so it doesn't get contaminated. So these workarounds to the usual use of PPE remain in place because we don't have full and complete confidence that the PPE supply chain has been resumed in a robust manner. The health systems are now also having to face the need to take care of both patients with COVID, but also provide the needed care to patients without COVID. In fact, there have been several articles that have expressed concern that as a result of the pandemic, patients are foregoing screening examinations. They're not able to get their colonoscopy when they need it. They're not able to get cancer diagnostic care when they need it. And we have to guard against those things because that will be the collateral damage of COVID-19. So health systems have to make sure that they deliver both COVID and non-COVID care at the same time. All of this sort of relentless marathon, plus infections in healthcare workers that we see as a consequence of sometimes infections from the community, but sometimes infections in the health system, because as a group, healthcare workers do have an occupational hazard and a risk of exposure to COVID-19. And so all of that fatigue, exhaustion, and burnout are things that have been reported in multiple papers recently and have to be addressed and guarded against. I think that testing challenges continue along with the under-testing that has been well reported. There's also this issue of over-testing. In the beginning, there was this feeling that patients should need a second test after they had recovered from COVID to show that, in fact, the virus had been eradicated. And all that showed was that you can have persistent PCR positivity for several weeks, even months sometimes in patients. It doesn't mean you're contagious. It doesn't mean you're sick anymore. But once someone sees a positive test, they find it very difficult not to react to it. And what that means is if you get hospitalized, you may be placed in isolation precautions again. A lot of PPE may be used for your care. And if that's not necessary, then we're not being good stewards of our resources. So those are some of the challenges that have only come about as we have learned more about how the natural history and how the trajectory of COVID is likely to continue in the health system. Next slide. So to summarize, the management of COVID-19 has improved by leaps and bounds, together with some new therapeutics that have been developed. However, the true efficacy of many treatments remains unknown, with the exception of corticosteroids. Vaccine trials, absolutely, it is imperative that they follow a very rigorous pathway to avoid the more haste, less speed problem, which would lead to a complete dissolution of trust by the public and will make it very difficult to implement this, even if it is found to be effective. So I will stop there and turn it over back to you, Mike.
Thank you, Dr. Safdar, for that great tour of what's going on in treatment here on the ground at UW and elsewhere. Really appreciate it, and look forward to hearing from you again in Q&A. Our next guest, Dr. Safdar, alluded to the fact that we'll be doing vaccine trials at the University of Wisconsin, and I'm pleased to report Tom Friedrich was one of the first to sign up. So, Tom, thanks for joining us tonight. Dr. Friedrich received his bachelor's degree from UW in '97 and his PhD in 2003, and is a proud third-generation Badger. He's a professor of pathobiological sciences in the School of Veterinary Medicine and is a renowned expert on the evolution, immunity, and pathogenesis of RNA viruses. The Friedrich Laboratory studies the origin of viruses and why they make us sick. He recently discovered evolutionary bottlenecks in influenza virus transmission that could affect how bird flu jumps to humans. During the Zika and COVID-19 outbreaks, Friedrich has collaborated with UW School of Medicine and Public Health colleague David OConnor to pioneer ways to share information from experiments in real time. This has facilitated faster and more cooperative research around the world. Tom, it is great to have you back. Thanks for joining us, and tell us about some of the in-depth work that's going on in your lab and others right here at UW.
Thanks, Mike. It's a real pleasure to be back with you. So I appreciate the invitation, especially being part of this really outstanding group today. Let's have the first slide. And what I really like to do is build on what Phill and Nasia talked about to sort of set the stage for discussing a study that we're doing here at UW-Madison to try and improve access to testing. So as I think everyone is aware, there's a massive problem with access to testing. And so we need to be able to test enough people to detect infections. And as we'll see over the next couple of minutes, I think that we may have been thinking about testing incorrectly. So what we want to do in our study here at UW-Madison is ask whether testing saliva instead of the nasal swabs that you may be familiar with might facilitate faster, more rapid turnaround and more frequent testing of people so that we can identify people who are contagious and get them to isolate faster. So that's the title, the origin of this title. All of this work was done by a number of labs here at UW-Madison and has been spearheaded by my friend and colleague David OConnor in the School of Medicine and Public Health. Next slide, please. So this is just an overview from the New York Times showing global hotspots of COVID circulation. So these are the countries in red with the highest number of average daily cases. And you see that the United States, unfortunately, continues to be a global hotspot for new COVID infections well into the pandemic. Next slide, please. If you delve down into the numbers, the number of US cases per day over time is shown in this top graph. And as we're all familiar with, we had this sort of peak of new infections that occurred in late July, early August nationwide. That was reflected also here in Wisconsin, as we see in the lower graph. And there are a number of states, unfortunately, Wisconsin included, that are beginning to see a very troubling uptick in new infections just in the past couple of weeks, coincident with the resumption of in-person schooling. And so we actually had a record-setting number of new cases in Dane County just today. So this is something that all of us are watching with some alarm. Next slide, please. So I would argue that expanded access to testing for the coronavirus is really an important piece of ending the pandemic. And I just want to unpack a few of the main reasons for that. The first is that studies suggest that people who don't have any symptoms may be very important in spreading the infection. One study suggested that maybe half of all infections were spread from somebody who didn't or didn't yet show any symptoms. So that means that if we only test people after they develop symptoms, we're missing a lot of opportunities to identify contagious people, get them to isolate, and control the spread of the coronavirus. And furthermore, testing is really used to guide real-time policy decisions. So the proportion of positive tests in a location over time and the number of new cases are important metrics that governments at the national, state, and local levels use to drive policy decisions. So, there's sort of a gatekeeping metric that will decide whether school is going to happen in person, for which grades, on what time frame, and so forth. So testing is really critical to inform our response moving forward. And in my lab, we are working with many others here at UW and actually around the world to develop new testing strategies. And what we're focusing on here at UW is to use strategies that will hopefully help schools and workplaces open as safely as possible, as quickly as possible. And as I mentioned in my spring presentation, also, our real focus here is on cooperation and openness across labs, not competition. We're not interested in being first. We are interested in doing a good job, but anything that we learn, we want to share with others as quickly as possible. Next slide, please. I'm also pleased to say that most of our colleagues around the world feel the same way. So about a week or so ago, you may have seen this story in the New York Times, which made some important points, and they really distilled for us the concepts behind the testing approach that we're evaluating here at Wisconsin. And it basically says in this article that the PCR-based tests that are commonly used may have two key problems. They may be too sensitive and too slow to use them to contain the spread of the coronavirus. So I'd like to unpack that a little further also. Next slide, please. So this is data from a scientific study that was published in the New England Journal of Medicine. And what people did here was collect swab specimens from people with COVID-19 on various days relative to symptom onset. Some gave samples before symptom onset. Those are the negative numbers on the x-axis. And then there are other time points throughout infection. And then they use this very sensitive PCR assay, which is the gold standard diagnostic test used to detect infection. And the y-axis shows from bottom to top increasing amounts of the viral genetic material, viral RNA, that's detected by the sensitive PCR test. These data points are colored red if the scientists could grow infectious live virus from that same sample. And they're colored black if they could not detect live virus in that sample. And so what you see here is that there's sort of a level of test, of this PCR test, below which it's really difficult to detect live virus that would be associated with somebody being able to spread infection to someone else. So this shows that there's a level at which you can test positive in this PCR test, as Nasia was saying, but you might not have a contagious level of virus that you could spread to someone else. So that means that we don't need a sensitive test like the PCR test to detect people who are contagious, which is really what we want to focus on for controlling spread. Next slide, please. So we have to think about the testing regime, not just testing an individual person. So I would argue that we want to be able to maximize the number of infected people that we rapidly detect in the brief window in which they're most likely to spread infection to someone else. And we have to remember that those people might not be showing any symptoms when they're in that window. So we have to think about the efficacy of our testing regime to detect as many contagious people as possible, not really the old way of thinking, like I want to detect the most virus, the most sensitive way in any given one person. Next slide, please. So the idea that we came up with here at Wisconsin, building on the well-known phrase sifting and winnowing, was that we want to perform a winnowing test. So we want to rapidly identify people who are contagious. To do that, modeling studies suggest that we have to test people frequently, even if they don't have any symptoms. So at a school or workplace, you might be asked to be tested twice per week. To make that more tolerable than having a Q-tip jammed up your nose multiple times in a week, we decided to work with saliva, which also contains virus. It's much easier to spit in a tube more frequently. We can use research grade tests, so we don't necessarily need to work in a clinical lab or have FDA approved tests to do this sort of winnowing procedure. And this can allow us to identify people who are likely to be positive. We can't provide a diagnosis, but what we can do is relieve pressure on clinical labs and just refer people who test positive in a research test to get a clinical lab follow-up test and confirm their presumptive diagnosis. So same-day turnaround with this less sensitive test is more important than being as sensitive as possible. There are multiple approaches that we can use to do this kind of testing. The one that we're using here at UW is called LAMP, for loop-mediated isothermal amplification. It also detects the viral genetic material like PCR does, although it trades sensitivity for some speed. And we look forward to getting much more robust and even faster antigen-based testing, so protein-based testing in the near future, but that's not available widely yet. So we're doing this as an IRB-approved research study here at UW-Madison using this LAMP procedure. Next slide, please. So these images just show that we can bundle all of the equipment necessary to do this pretty simple test into a van, which you see in the upper left here. We can take the entire test procedure, including the test itself, to you. So here we are at UW-Madison workplace, collecting samples from people in the upper right, and then actually doing the test itself at an outside laboratory set up on a couple of card tables on the bottom image. So this shows what we need to do to be able to test rapidly is actually bring the test to the place where we're doing the testing. Next slide, please. So this just shows that the entire procedure, including setting up the mobile lab and taking it down, takes about 2.5 hours if we're doing this as rapidly as possible to get results back and contact people if they test positive in this test. Next slide, please. I'm going to go fast because I want to leave time for people's questions. So we have results so far that you can look at this preprint that's on medRxiv right now. We've tested over 2,000 people over the last 6 weeks at sites in Dane County, including a local elementary school, 2 workplaces here at UW-Madison, and a high volume of people, including student athletes at the UW Athletic Department. What you can see here is how this test works. So we add a little bit of saliva to these little mini tubes that are loaded with a reaction mix that is read before the test starts. And after half an hour, if the sample contains genetic material from the virus, the tubes turn yellow. And so in the middle on the right, you can see an individual who tested positive in this research test, and subsequent PCR-based testing showed that they had a very large amount of virus in their saliva, which is consistent with contagiousness. So here we're able to rapidly identify an infected person who may be contagious and get them to isolate pending the results of a confirmatory diagnostic test, which is exactly what this procedure was designed to do. Next slide, please. So I think that this type of winnowing testing has an important future as part of the pandemic mitigation toolkit. Just recently, the Centers for Medicare and Medicaid Services ruled that this sort of testing, which they call surveillance, can be done using research-grade tests and can be done in non-clinical labs. So this can, as I said, relieve pressure on clinical labs and help dramatically increase access to testing for people who need it and get results rapidly. So one of the main questions that we're addressing in our research study here at UW is what are the obstacles to expanding this kind of testing? So how can we expand it most effectively and get it to places where it's most needed? Our medical school colleague, David Beebe, is developing this into a mobile automated version using the same sort of approaches that we're doing here with support from NIH's Rapid Acceleration of Diagnostics, or RADX program. Next slide, please. So this is the final slide, and I was actually up north on vacation when we had a really big meeting, and this just shows some of the people involved from my lab, the lab of David and Shelby OConnor, and other UW-Madison labs. Although we're socially distant, we meet regularly to talk about our progress and plan how we're going to do all of this testing. And so these are students and technicians in all of our labs working together to hopefully make this testing better and show how it could be more widely available, hopefully in the near future. I'll end it there and leave some time for everyone's questions. Thanks for your attention.
Great. Thank you, Tom, for that dive into the research going on here in your lab and elsewhere. It's great to hear about that. Let's get things rolling on questions. So I have a question that probably belongs for Nasia or Phill, and also a follow-up to it. Is the U.S. treatment experience and the improvements we've made the leading edge? Because it seemed like the virus, hit other countries sooner. And I'm wondering, did we learn things from the Italian experience or the Chinese experience that helped inform what we did? Or are the treatment improvements that we've seen largely things that our system uncovered?
Well, I think from the prevention standpoint, we learned a lot from the Chinese experience and how Italy handled the pandemic. So, what PPE was the best one to use, how to avoid health system getting overwhelmed, for instance, with patients that needed care, how to manage some of that work. I think as far as therapeutics go, I would say everybody largely learned at the same time. But some of these trials, yes, were undergoing in those other countries before they could happen in the US, just because the volume of patients was much higher there. So there was an opportunity to learn from them too.
And I would just say there was a lot of sharing of data, the anticoagulation issue that was happening, as Tom mentioned. There are a lot of, and even today, there's some new data that's coming out about where the inflammatory cascade is coming from in COVID. Is it coming from the bradykinin system rather than sort of the immune response, since the anti-inflammatory drugs that were designed to tamp down the immune system have all failed? And that being shared real time with everybody in the world. These preprints have become common now. They don't wait for peer reviewing of the data. They just get it out there and let people think about it and try to incorporate it into their treatment paradigm.
Yeah, I would just say that one thing that's been really striking from the scientific perspective is how much people worldwide are willing and happy to collaborate. So, I mean, Mike, you alluded to the system that Dave O'Connor and I set up early on in the pandemic, and that was just one of a huge number of groups that have been organized by NGOs and just individual scientists and everything to share results as quickly as possible. And I think there's really been a focus on trying to get things right, as opposed to kind of going for the glory and being the person who discovers things.
There's a lot of discussion about, how well is the U.S. doing in really battling the coronavirus, and probably depending on which news source you go to, either we're doing great or we're terrible. And, one of the things I wonder about, what do we know about what's happening to all-cause mortality in the United States compared to other countries? I know there are ways of, just because of the law of large numbers, there's a certain number of deaths per week or month that you can expect in our population that tends to have a fair bit of stability. What do we know about that in the United States compared to, say, other countries? Any information on that?
I think from the standpoint of, reporting of deaths is a bit of an issue that is somewhat fraught with problems, especially when it comes to reporting of COVID-19 deaths. The question that's being asked is, did the individual die of COVID or with COVID? It certainly didn't help their overall life expectancy in any way. There was a recent paper in JAMA that looked at the excess mortality from COVID compared to the overall baseline mortality that you might expect, just given the population demographics that we have. And there was a considerable amount of excess mortality from COVID. I think we will really only know about overall rising mortality or not rising mortality several months into the pandemic, which is still too soon, because of things like preventable cancer-related deaths, for instance, or other things like cardiac deaths that we don't have a full picture of at this point.
Thank you. Yes, I'd seen that study, and I think it estimated about 200,000 excess deaths in the United States to date versus, the other attribution of 170,000 or so to COVID. But I think that attribution is an interesting question. And, as we've all talked about, you have other deaths caused perhaps by people staying away from the health system. Question from Levi Hogan. What do we know about false negative rates for PCR tests? are they as high, especially for asymptomatic, as some of the initial information a few months ago? And how do these rapid tests compare? Tom?
So that's a really good question. So false negative would mean that you get a positive result in this test, but you don't really have the infection. PCR is very sensitive, and it's very specific. So we expect the false negative rate in PCR tests to be pretty low. And the data that I've seen suggests that's the case. We've heard a little bit about the potential for false positives because, things will happen, unexpected things will happen once you start doing a lot of testing. And if the background rate of infection is very low, then we might expect some proportion of tests to actually be false positives, to not really be real infections. And that was more of a concern early on, false positives, actually. With the rapid antigen tests and the rapid LAMP test that I talked about, there is the potential for false negatives in the sense that someone could test negative in this rapid test. And then if you tested that same person at the same time with a PCR test, they would test positive. But I think that the way to look at that is while you test positive with this PCR test, it may actually not indicate the presence of infectious virus. So the whole point with that article is that PCR testing may be too sensitive. As Nasia alluded to, if someone has been infected for a long time, they may remain persistently positive by PCR, but they may not actually have infectious contagious virus. So I think where testing needs to go a little bit more is looking for asymptomatic people who test positive with a high viral load that would be consistent with potential contagiousness. So their false negatives, they could maybe happen, but we're willing to take that because we could rapidly identify people who should most rapidly isolate.
Thanks, Tom. A question on what do we know about the likelihood and severity of long-term impacts COVID is having on people short of death? So, for example, I guess maybe the primary concern of athletic directors and chancellors and presidents in not playing football right away in the Big Ten is something called myocarditis that they're finding in some of the athletes who test positive. But I'm sure there are other things we worry about. What do we know about those long-term impacts, their likelihood and severity?
Well, I think one thing we know is that it takes a huge toll on the respiratory system. As an acute infectious respiratory condition, particularly for people that need ICU care, you not only have your lungs that have to recover from it, but all the other, the toll that it's taken on the rest of the body, just like it would for any other ICU condition. And initially it was felt that, you either, recover quickly or you might recover in a few weeks, but because it's acute and infectious, it's a matter of weeks and not longer than that. And that doesn't appear to be the case anymore. There are people that are still reporting shortness of breath, fatigue, exhaustion several months after the illness. In terms of organ damage, I think myocarditis is the one that has been most well described, although there is still a lot to be learned about that. And how and for how long that happens, I think, are somewhat unresolved at this point.
Dr. Safdar, we got another question that I'm going to direct to you, and that is in the hospitalizations that we're seeing at UW, do they almost entirely come from Dane County, or are we treating people from outside Dane County as well?
We have a large catchment area, so we are treating people from outside Dane County as well. And as a referral center, UW Health is often the destination for many people that need critical care outside of Dane County.
Phill, John Deals wonders, is there any reasonable way to quantify the financial cost of the pandemic and our reaction to it? So in addition to, I guess, the mortality, the load on the health system and shutting down the normal course of life, what would you say to that?
Boy, that's a tough question. I haven't seen anything, although I've seen obviously the GDP numbers that everybody else has seen, which is one way to quantify it, but there's a lot more that people are just talking about now when it comes to depression, comes to all the psychological impacts that have happened here. It's just going to be one of those things that there'll be numbers thrown around, but it's really going to be hard to quantify the real long-term impacts of this. I do think our behavior is going to have to change, around, anything that starts out looking like COVID-19 again down the road. And so this is going to be a constant, it could even be COVID-19 that's still around in the future. There's a lot of changes that are going to happen.
Yeah, I'm sure that question will be researched for a long time, and it will be hard to reach a clear conclusion. Yeah. Question from Charles Weiss. What protocols are being developed for allowable activities as growing numbers of people have the vaccine? Will people with and without the vaccine have different rights of access to, participating in group events or services? How do you think that might roll out? I'll throw that out to the three experts, and you can fight over that one.
Well, I think that there are already vaccines that are mandatory for participation in certain things. I mean, you could imagine a situation where, where the vaccine becomes mandatory for kids attending school or something like that. I think that that's a ways off, though, because as we've already heard from Phill, vaccines are not going to be widely available for some time, and there's going to be some time after the initial rollout before there's herd immunity. So I think it's also possible that there may be protocols around testing, just as we see, in the NBA bubble, say, if this sort of winnowing testing becomes more widely available, then that could be a way to make sure that people, that a workplace or a school is safe. The rapid antigen test that was just developed by Abbott comes along with an app on your phone that you can use as kind of a passport, sort of time-limited passport to say, like, hey, I just tested negative in this test, so let me into this event or let me into work today. So you could imagine a situation where that happens, but there's no, to my knowledge, national or state jurisdiction over these types of decisions. They're very patchwork.
Thanks, Tom. Question from Brett Hawkins. What are the range of efficacies expected for the vaccine? Is it going to be more like a flu shot or polio? Kind of where would you expect it to fall on that kind of spectrum?
I think I'll let Nasia talk about this as well, but I think the FDA sort of set a bar at 50% efficacy. The initial clinical data will be looking at that as sort of proving that it's at least 50% efficacious in those initial infections, those 50 to 150 infections that they see, and I think most people expect that they'll be a little bit better than the flu vaccine, because the flu vaccine has strains that kind of escape the vaccine each year. This virus has been pretty well preserved, so we think if a vaccine's effective, there's not going to be a lot of genetic drift in the vaccine. So I think most of the estimates are in the 60 to 80% range. Respiratory virus vaccines are also notoriously difficult to get these kind of results that are clean, which is why they're going after symptomatic patients, not just infections. And all of them have a secondary endpoint that is severe infections that require hospitalizations. These vaccines may very well do a better job preventing people from being admitted to the hospital than they do preventing initial infections, just because of the nature of respiratory vaccines historically. And I'm sure Nasia can add to that comment.
No, that was a great synopsis, Phill. Nothing to add.
Question from Scott Rogoff, and I think this is headed to Tom. Scott says he has heard that the gargle test developed in Israel is 95% accurate, returns results in 5 seconds, and costs 25 cents, and the analysis machine is $200. Will that test come to the U.S.?
Well, I'm sorry, I'm not entirely sure what test that refers to. But broadly speaking, there are rapid tests like this that don't detect the virus genetic material, but detect like the virus particles themselves in saliva or nasal swabs, and they do return results in as little as 5 minutes. I don't know about 5 seconds, but certainly very rapidly. So they could be there while the person being tested waits. They work kind of like a pregnancy test where you sort of get a color change on a strip, and you see that if the person tests positive. So these types of tests are absolutely coming to the U.S. But like a lot of our testing, they're going to be dependent on exactly which company is able to provide how many tests to which group that's in need. And so, in our own lab, we're really interested in evaluating this Abbott test that's coming out soon, which shows a lot of promise if it lives up to how it's been billed.
Tom, do you envision testing shifting from a binary outcome to more determining how much virus is present when someone's positive?
That's a really good question. So something that we do in the HIV field is we don't just say someone is HIV positive, but there's a lot of information that we can get from how much HIV is present in their body. And similarly, it would be really nice to know like the results from these PCR tests come with an amount of virus that's in the swab. And, even though the result is reported back as positive or negative, there's more in there. And, we're beginning to look for correlations between how much viral RNA is detected in these tests, and whether that indicates that someone is likely to be contagious. So it would be great to have the so-called viral load information in addition to just positive or negative.
Dr. Safdar, what is the conventional wisdom today on the isolation time period once there's a positive test?
So for patients with symptoms, it's 10 days from the onset of symptoms, assuming that one is recovered by that time for most people. For people whose immune systems are compromised, you may have a prolonged illness, and so it's 20 days from the onset of symptoms for that group.
So that means we would think you might be contagious for that amount of time, and after that amount of time, you're no longer infected?
That's right. You're most contagious early on in the illness, but I think some of those studies that have been done to compare and look at when contagion drops off, 10 days seems to be a good place to end.
Should we get our seasonal flu shots early this year?
Well, they've started already in most health systems. So yeah, first week of September would be a good time. Maybe Tom, you have something to say about that.
Certainly getting your flu shot is better than not getting your flu shot. And so just do it and get it out of the way. That's better than not having it. It's going to be really difficult to predict what will happen during this flu season. So in South America, where they're wrapping up their winter, they had a lot less flu activity than is normal. And people are speculating, well, is that because social distancing has effectively contained flu spread, or is COVID kind of displaced flu? We don't know, but it's going to be a big challenge to tell the difference between influenza and COVID if they're circulating at the same time, and the indications for how you might take care of somebody or what you might recommend they do, like self-isolate or not, would be important to tell the difference. So the less flu we have, the better, and getting vaccinated will help reduce the flu burden.
Moderator's done a bad job tonight. I've abused your time. We're already 10 minutes past the top of the hour. But I would like to give each of you a chance if there's something more you wanted to comment on before we wrap things up. I'll go around the horn first to Phill.
Yeah, I'll say something about vaccines. I do think that we're all going to have a much clearer view in March, April, May of next year as to what the right way to go personally is. It's a long time to wait, but that's when all the data will truly be comparable. I think one of the things to worry about is that some of the populations that are most skeptical about vaccines and vaccinations in the healthcare system and participating in the healthcare system in general would be some of the most vulnerable populations in the urban centers. And so I do think that if you look ahead to a year from now, there's going to be probably going to be COVID-19 out there. And it's unfortunately going to be in some of those areas that are the most vulnerable, where people are forced to live close together. And there'll be these sorts of outbreaks that we're going to see that I just think is something we're just going to have to realize and live with, even with the vaccine.
Thank you. Nasia.
I think I would just say, until we have a safe and efficacious vaccine, we are left with the two things that only we can control, which is universal masking and physical distancing. So these are interventions that are challenging, they're fatiguing, they're exhausting, but now is not the time to let up. So just a plea to everyone to continue those until we have some other solution to COVID.
Bear down. I like it. Helpful. Good reminder. Tom.
Well, I'll just quickly actually combine those two remarks and say that, from all the preclinical data that's out there, I'm confident that vaccines will likely work pretty well. I think that we should have some good options for safe and effective vaccines. But it's important to remember, as we've been talking about here, that the announcement, the day they announced that a safe and effective vaccine is available, is not the end of the pandemic, but it's more like the end of the beginning of the pandemic. I think COVID is definitely going to continue to be with us for a while, and that means that we are going to all have to adjust our behavior, and those are the ways that we can keep the burden low until we get a universal vaccine that's widely available and can hopefully produce herd immunity.
Well, I would like to thank all of you and congratulate all of you for being selected to our first ever all-star team of UW Now. We brought you back a second time. So thanks for joining us. Really appreciate it.
Thanks, Mike.
Great to have you with us. Just a plug for a few more events we've got coming up in the near future. This Thursday at 7 p.m., Coach Greg and Michelle Gard will be hosting the 4th annual Guarding Against Cancer event virtually. I know you can find the information for that out in the chat stream. Next Tuesday, the Wisconsin Medicine live stream series continues with an episode on ending Alzheimer's. And then UW Now will be back again on Tuesday, September 22nd to talk about the future of data science. Our guests will be Remzi Arpachi-Dassault, the Grace Waba Professor and Chair of Computer Sciences, and Eric Levkovsky, the founder of Tempus and co-founder of Groupon. So that should be a fascinating episode as well. So thanks for being with us tonight, and on Wisconsin.